Hello everyone. So in this video we are going to talk about general principles of fracture treatment. These are though non-specific but can be used for any of the fracture. These involve emergency care, definitive care and rehabilitative care. The emergency care involve the mnemonic RICE, that is rest using the splint that can be made of any material thing available at the point of injury. We have ice packs, okay, to reduce the swelling. We have compression bandages and elevation to reduce edema. The neurovascular deficit can be checked by feeling for the distal pulses and neuronal functions. Talking about definitive care, the aim of the definitive care is to reach the function of the joint to the pre-injury level. Okay, contrary to the earlier aim, which was just to make the union of the fracture. The steps involved in definitive care is reduction, immobilization, and preserving the function. Here, preserving the function starts at the point of injury only and continues even after the fracture is immobilized. This is done by physiotherapy. Talking about reduction, reduction is realignment of the fracture to the normal position, and immobilization is maintaining that realigned position. The reduction is not always necessary, like in a fracture of child clavicle, the reduction may not be necessary. The methods of reduction can be closed manipulation. In closed manipulation, expertise and experience, feeling for the soft tissue around, and then closely manipulating the fracture helps. Okay, nowadays image intensifier are available which have made this method far more easier. Talking about another method, that is continuous traction. As the name suggests, a continuous traction or the force is applied to keep the joint in the reduced position. Consider this patient has an intertrochanteric fracture. Okay, because of the muscle pull, the fracture segment cannot be aligned without a traction. Okay, so here we have applied a traction at the leg of the patient by putting a weight, and this causes and counteracts the force of the muscle acting on the fracture point as well as the gravity, and helps in reducing the fracture. The third method is open reduction. Open reduction is directly visualizing the fracture points and then realigning them. Okay, with plates and screws we immobilize it too. The open reduction indications are what everyone needs to remember. These include the physial fracture involving the physial point, the fracture which have not reduced by close manipulation, also the fracture that involve the joint itself, means interarticular fracture are the one. So these are some of the absolute indications of the open reduction. Talking about immobilization, the aim of or the causes for immobilization to be done is, if a fracture was requiring reduction, invariably it will require immobilization, because most of the fracture without immobilization will return back to the position of fracture. The immobilization, the main point to be noted is that immobilization relieves the pain. And the third thing is, the new capillaries that are formed at the point of fracture are fragile, and if it is not mobilized, there will be no union and these capillary will break again. So the immobilization helps in union of the joint. Talking about the methods of immobilization, we can have either the non-operative methods or operative methods. Non-operative methods include strapping, sling, cast and functional bracing. The strapping, here we use something to bind the fracture with the adjacent bone available. Bandages, okay, we use bandages to tie the fracture with the adjacent finger, like a fracture of the phalanx, distal phalanx, proximal phalanx, you may see in cricket players, basketball player, they tie the using the bandages with the adjacent finger. Talking about sling, these are generally used, these suspend the fracture and stabilize it. These are generally used in upper limb fractures, okay, like the triangular sling that is used in clavicular fracture. Talking about cast, this is the most common method, that is most common non-operative method of immobilization. There is a different video or the specific video talking about POPs, that is plaster of Paris, that is gypsum salt, that is most commonly used for cast. Another method is fiberglass casting tape. These are in widely used nowadays because these are radiolucent and X-ray can visualize through them. The final method is functional bracing. This method is used in a stable joint. Okay, here what we do is The joint above and below the fracture point are not immobilized, only the fracture segment is what is immobilized. One more thing we needed to know about continuous traction is its disadvantages. The continuous traction makes the patient bedridden, and these are prone for bed sores. Nowadays, what if the patient is continuous traction, what we do is, if the patient develops the sticky joint, okay, if he has developed callus and some stability in the joint, we advise the patient to have a cast and then get mobilized to have faster or rapid healing. So this was about reduction, immobilization, and preserving the function using the physiotherapy starting at the point of injury itself. So now we will talk about the rehabilitation of fracture limb. That is the third step. In this step, we start this rehabilitation starts from the point of injury and continues till the maximum function of that joint is achieved. This involves three things: the joint mobilization, muscle re-education, and functional use of the limb. Talking about joint mobilization, now there is adjacent joint getting stiff in the case of fracture. Now why this is? Because of immobilization. The second reason for the stiff joint is the pain that is occurring, and itself injury to this joint can cause this stiffness of the joint. Now what we do for joint mobilization is, we advise the patient to go for passive mobilization. Okay, the active mobilization that can be assisted by an assistant or the family members. Active himself, he himself tries to actively mobilize the joint or using it. Nowadays there are continuous passive motion machines that are available, CPM machine. These cause the joint movement at a specific range and changes with time. Talking about muscle re-education exercises, they can involve the static contraction while the fracture segment is within a cast and not a lot of movement is available. The static contraction using the surrounding fingers and the muscles can be used for contraction of the muscles within the cast. The dynamic contraction after the fracture cast has been removed. Dynamic contraction and the static contraction help in reducing the muscle atrophy following a fracture. The functional use of limb more and more will help to regain the function maximally. Okay, so this was what we needed to know about the general principles of fracture management. Thanks for watching.